there are so many other books for which he has contributed chapters. Now, I hand over the mic to Dr. Mohan T to introduce the renowned speaker of the day for the first session.
Thank you, madam. Am I clear, ma'am?
Yeah, it's clear.
Okay. Thank you, Dr. Siby, Dr. Rugmini. Thank you, madam, for the kind introduction also. Thank you, Vijay Kumar sir. Thank you, all the senior members who have joined today and also the fellow colleagues. So to introduce Dr. Ahila Ayyavoo, ma'am, she is working in Coimbatore, and she is working as Kuppuswamy Naidu Memorial Hospital, Coimbatore Teaching Hospital. She has done her training PhD from Auckland under the supervision of Professor Wayne Cutfield. She has done PhD as well as clinical fellowship in pediatric endocrinology. I know madam from the last 5 years because when I was a DM student in Amrita, I had gone to Coimbatore to attend a growth hormone symposium, and from there we have regularly met at various ISPAE, which is the forum for Indian Society of Pediatric Endocrinology. So madam is very distinguished speaker and holds a lot of honors, and basically she is a very good researcher as well as an academician. She has done several projects and currently does a project regarding developmental outcomes in children diagnosed early versus late in congenital hypothyroidism, as well as so many researches on Turner syndrome and vitamin D status. So without much ado, I'll hand over the podium to Dr. Ahila Ayyavoo. Over to you, ma'am.
Good evening, everyone. Can you hear me well?
Yes, ma'am. Yes, ma'am.
Thank you so much for the kind introduction, Mohan. It's a pleasure and an honor to be here today. And I'm deeply thankful to all of you to have such wonderful friends like Dr. Vijay Kumar, Dr. Mohan Shenoy. I can see Dr. Sangeeta Yadav in the group also. And then thank you so much, Dr. Rugmini Madam and Dr. Siby for this kind invite. And I hope I can make it interesting. And thanks to all the distinguished guests in this meeting today. And I am sorry if I haven't mentioned you by name. I thought we'll just start off with the meeting. I may not be covering the whole of the standard treatment guidelines that we have actually published. And I owe a deep round of thanks to my co-authors, Dr. Ravindra Kumar from Delhi and Dr. Tushar Godbole from Nasik, who are my co-authors for the standard treatment guidelines. And I think I cannot start the meeting without thanking my own mentor and Professor Raghupati, who's actually would be journeying along with me through this topic, because I think all our patients come together. I can't say they are my patients, it's our patients. So we will just start off. Okay. Thank you. And thank you so much, Mohan, for the kind words. And thanks, Vijay Kumar. It's great to see you today. And I'm missing Riyaz today. So this is something I don't think all of us would have the opportunity to see such an obvious presentation of thyroid disorder in a newborn. So these are very, very rare to see, to have a deflexed head with a huge goiter. These are not the usual occurrences that you would see. And I'm thankful to Dr. Ravi Kumar for these slides. Okay, these are 3 of my patients which have been referred to me as patients with hypothyroidism. Look at this obvious protrusion of the tongue. This child has an umbilical hernia. The eyes are bright, so you don't know whether they are hypothyroid or not. And then you have this baby who looks bright, does not have too many features, but because of constipation, somebody had investigated. And these are not newborns, are just beyond the newborn period, about 3 to 6 months, and this child was about 8 or 9 months old. And all of them had been referred for evaluation of congenital hypothyroidism. But if you had done newborn screening, both these children were actually not hypothyroid. They just did not like to keep their tongue within their mouth and just kept protruding. And this was again an incidental finding, and both of these are absolutely normal euthyroid children, whereas this child who had been investigated for constipation had hypothyroidism. So this is to just highlight the fact you need to screen for thyroid gland before clinical features are obvious. There is no point in waiting for clinical features to be manifested before you diagnose hypothyroidism. As Mohan had mentioned, we just finished off our study on neurodevelopmental outcomes in children diagnosed early and treated and those diagnosed late. We just looked at children diagnosed before 1 month of age and those diagnosed after 3 months of age and compared them and their developmental quotient using Denver Developmental Scale with their normal siblings who were euthyroid. And what we found was in patients who were diagnosed after 3 months of age, the developmental quotient was about 13 to 14 points less than those who had been diagnosed and treated before 1 month of age. So it's important to remember you cannot wait for clinical features to happen. So we will go along and I will be using my standard treatment guidelines published by the IAP as a reference for all of these. It's a full-term normal delivery baby. Cord blood TSH. We use cord blood TSH screening in our hospital from 2005. So this was more than 150. What should we do? This child has not got any of these clinical features of hypothyroidism. Whenever the TSH is more than 40, send confirmatory venous sample after after 72 hours, and then don't wait for the report to come back. You can immediately send for scanning and then work up the etiological diagnosis if it is possible in your center. If it is not possible, don't wait for the etiological diagnosis, start thyroxine. So this is a thyroid CT scan, which is what we regularly do in all our patients where we suspect congenital hypothyroidism. This is a normal thyroid gland in the neck. As this child, you cannot see any thyroid gland tissue at all. So this was an athyrosis. What is the thyroxine dosing in congenital hypothyroidism? The best outcomes or neurodevelopmental outcomes happen when treatment is initiated before 14 days of life. And the high dose thyroxine has been proven again and again to show better long-term neurodevelopmental outcomes. So 10 to 15 microgram per kg per day. And I'm not a big fan of breaking them and making like dissolve it in 5 ml of water, then take 3 ml. It's really difficult. Instead of that, you should remember that the half-life of thyroxine is almost 7 days. So you can calculate a weekly dose and prescribe so that it matches what you're looking for and give the nearest possible whole dose, which is easy for the parents to dissolve and give. So it is high dose thyroxine, 10 to 15 microgram per kg per day. Better outcomes are seen with this dose. Rapid normalization of TSH has better long-term developmental outcome. Further thyroxine doses are usually adjusted based on the thyroid function test. How would you follow up this child? T4 or free T4 after 2 weeks. If you can afford to do a TSH, you can do that too. It would actually be more helpful. But you don't have to wait. If your T4 and free T4 are already on the upper half of the reference range, in young infants, it's better to aim for a thyroxine level which is above the upper half because it's more important for your neurodevelopmental outcome again. And your TSH should reach the lower half of the reference range by 4 weeks because some of these babies could have TSH as high as 650,000. Sometimes we've even seen 1,500 and so. So you don't wait for it to completely normalize. You're only looking at coming down by 4 weeks. So for the thyroid function for follow-up, for the first test, it will be in 2 weeks. The second test will be in 4 weeks. After that, based on the diagnosis, the etiological diagnosis and the level of thyroid function test, the test can be done 1 to 2 monthly up to 6 months and 2 to 4 monthly from 6 to 36 months. We usually do every 3 months after 1 year of age. So this is one of our patients. This landed up at our clinic at 3 months of age. Look at the gross developmental delay and florid features of hypothyroidism. And that's the same baby about 2 months after thyroxine replacement. He's now 18 years of age. He's still following up with me. He's doing well, but definitely he's not been able to do very well at his academics. But that's fine. He's still having a completely useful and a normal life other than his academics. Okay, we go on to the next case. So this is a child who was born by full-term normal delivery. The cord blood TSH is 34. It's not totally very high, but what would you do? It's still not normal. So I would actually look at this busy slide. I think this is a part of the standard treatment guidelines and very, very useful. So we'll go one by one. You have a normal T4. Why do I keep on highlighting about T4 or free T4? We will come to this at the last slide of this presentation. So it could be a normal T4 and free T4 and TSH. So what is normal TSH? Anything less than 20 in the first 2 weeks is normal for babies. Anything less than 10 beyond 2 weeks is normal for children. So we don't treat children who have a TSH of 6, 7 and all that. So anything less than 20 in the first 2 weeks and less than 10 beyond 2 weeks is normal for children. Total T4 and free T4, it should be in the upper half of the reference range for age. Again, I have not mentioned what is the normal reference range, because the method of checking for these hormones in different labs around the country is different. So you cannot have a single reference range. It would be important to have your own reference range for the labs that you use. Okay, next scenario. So you have normal T4, free T4 and TSH. Here, the T4 and free T4 are low and the TSH is high. So no confusion. This is a normal hypothyroidism, primary hypothyroidism, because the thyroid gland is defective. You will immediately image for etiological diagnosis if you have radionuclide scan. If you don't have, do an ultrasound just to see the presence of thyroid gland. If it is present here, it is a dysharmonogenesis. If it is not present here, it is either an ectopic or an athyrosis. So it's a structural or a functional defect, can be made out just by the presence of thyroid gland. You can't make out anything else. So you image for an etiological diagnosis and start thyroxine immediately. Don't waste time. If you don't have imaging facilities, you've proven it as hypothyroidism, start treatment. Next, you have a low total T4 and free T4, but the TSH is normal. Then it becomes central hypothyroidism. Here again, you will start thyroxine, but remember, you will have to think of other anterior pituitary hormone defects like ACTH, which is extremely important because it will help to combat stress. You don't have to worry about LH, FSH, and growth hormone now. The most important other pituitary hormone you would check is cortisol. Okay, so you've now finished a primary hypothyroidism, a normal child in the repeat sample, and then you have one with central hypothyroidism. And the last scenario is you have high TSH, the total T4 and free T4 are normal, and in the higher range, on the higher half of the reference range. So what is this? It could be a transient hypothyroidism if there are maternal antibodies which has crossed the placenta, or it could be a slowly evolving hypothyroidism. You should repeat TSH after 2 weeks. If it is less than 10, all of us know in children that's normal, you don't do anything. If the TSH is more than 10 and persistently more than 10 after 3 weeks with normal T4 and free T4, you would still start thyroxine and worry about what is happening after completion of the neurological system and re-evaluate at 3 years of age. So this is probably the scenario that would have been present in this young child. It would have been an ectopic thyroid, and the CT scan can easily show. There is a marker in the scapular, I'm sorry, I just got this term. So suprasternal notch, you have a marker, and then you have a marker on the chin, and you can see there is a double ectopic in this child. So one at the lingual and one at the subhyoid region. We've got at least 4 or 5 patients with double ectopics. Or this could be a partial dysharmonogenesis or an organification defect. The uptake is slightly high. Anything 1 to 4% uptake of a technetium 99 scan is what we do, because we are far off from the atomic reactor in Bombay. So I-123 has a very short half-life, so we can't afford to use it. So we use technetium 99M. When we image, if the uptake is 1 to 4%, it is normal. It's slightly high. And then we do a perchlorate discharge test to prove it's an organification defect. This was which was being done earlier. Now I've just given up. If the uptake is high, I take it as dysharmonogenesis and just go ahead and don't do a perchlorate discharge test. But Professor Raghupati and his team continue to do, and they prove it is organification defect. What is the duration of therapy? Structural abnormalities like athyrosis, ectopic hemiagenesis, it is definitely lifelong thyroxine replacement for sure. Dysharmonogenetic or an organification defect causing congenital hypothyroidism. Treatment can be stopped for 4 weeks at 3 years of age to reassess whether it is transient or permanent congenital hypothyroidism, and decision can be based on TFT values over the past 3 years. What do I mean by this? If your TSH keeps jumping every now and then above normalcy, that means this patient cannot be normal in later life and will be thyroxine dependent. But some of them will be on a low dose of like 12.5 or 25 right to 3 years of their development. Some of them can be transient. We looked at 805 patients with congenital hypothyroidism. Professor Raghupathi's team and my center, we had 805 patients of congenital hypothyroidism, which was analyzed by Akanksha, who's a former fellow of SIR. And what we found was 6% of dysharmonogenesis can have a transient hypothyroidism. It's only 6%. So you have to remember that only 6% can be transient even in dysharmonogenesis. But it could be different in another center. But this was our data from 805 patients with congenital hypothyroidism. Okay, we'll go on to another scenario. You have a cord blood TSH of 10.2, and we kept on talking about 20, about 20 being abnormal, and below 10 being normal in children beyond 2 weeks of age. Okay, this child in a cord blood TSH is absolutely normal, 10.2. The child is clinically well. There is no thyroid swelling, discharged. During the first immunization, the child presented with slightly dry skin, passage of stools on alternate days, and subsequent immunizations showed slight delay in milestones. The pediatrician had seen that the cord blood TSH was fine, so he didn't think of rechecking again. But whenever you suspect clinically, you should still repeat a full spectrum thyroid function test, because initial screening may miss 2% of congenital hypothyroidism, that is 1 in a million population. Reasons: it could be a slowly evolving hypothyroidism, secondary or tertiary hypothyroidism, and slowly evolving hypothyroidism is something we frequently see in children with Down syndrome. Another point that I would want to make is, I know that Dr. Vijay Kumar has fantastic data, and their incidence is, I think, 1 in 1,500. The ICMR data published in 2018 showed an incidence of congenital hypothyroidism to be 1 in 1,150. But in our hospital, our incidence is 1 in 645. If you compare your data with the Western data, the prevalence of congenital hypothyroidism is 1 in 4,000, 3,000 to 4,000. Ours is far, far more common than theirs. The next point is 85% of congenital hypothyroidism is supposed to be dysgenesis or structural defect. Later, when the recent data from Dr. Ari Vasner from US said 60 to 70% are structural defects, whereas what we saw was 47% is actually dysharmonogenesis in the Indian subpopulation. So our rate of dysharmonogenesis is far more than what is seen in the Western population. So this is another of my patient, again, missed because they did not have a thyroid screening. And I'm really, really pleased and very proud of the fact that Kerala is doing such fantastic job with thyroid screening and all other programs for children. Here, this is a child who's 6 months of age, completely hypothyroid, and then picked up by a pediatrician during immunizations. And then she came, and now she's almost 8 years of age, doing very well. Actually, she's done well in academics too. So don't give up hope. Just because you're a congenital hypothyroidism and you were diagnosed late, you may do a little bit badly in academics, but otherwise they do really well. Not everybody can study very well and get score 100 in mathematics and all that. Even an average person may not do well in mathematics. That's okay. So you can still have a useful life. Focus your life on different targets instead of just academic targets, and they can have useful life. So whenever you diagnose congenital hypothyroidism, if they subsequently continue to be careful about taking their drugs regularly and being on regular follow-up, ultimately they do really well. This is again an example of that. Okay, now we go on to the next part, which is acquired hypothyroidism. So again, I forgot to talk about the dosing. What is the dose we use in congenital hypothyroidism? You remember it was 10 to 50 microgram per kg per day, which is what you start off. At 2 weeks of age, after checking the thyroid function test, I drop it down to 100 microgram per meter squared per day. The physiological secretion of thyroxine by humans is roughly around 80 to 120 microgram per meter squared per day. So we are using thyroxine replacement to match that. And we subsequently alter the dose based on that thyroid functions. If it goes, the requirement goes beyond 120, there are 2 or 3 possibilities. One, compliance. The family is not giving it directly. Second, The thyroxine TSH set point in the brain has been set high in some patients with athyrosis. The third point is thyroid hormone resistance. So you have to remember, you have to keep all this in mind when you're monitoring your therapy. So this is a 14-year-old girl who has obvious signs of hypothyroidism. A distended abdomen, dry striae, mild thyromegaly, scaly skin, a non-peating pedal edema. So this is an obvious case of acquired hypothyroidism. What would be the dose in acquired hypothyroidism? The thyroxine dose is based, as I already mentioned, on the body surface area. It's 100 microgram per meter squared body surface area. I also use a formula only by weight where you can calculate body surface area. That is 4W plus 7 by W plus 90, where W stands for weight. That also gives you a body surface area if you're unable to measure length or height. So remember, in congenital hypothyroidism, you start at the highest dose and then drop down to improve neurodevelopmental outcomes. On the contrary, in acquired hypothyroidism, you start at a lower dose and climb up slowly, particularly if your TSH is very high. In long-standing untreated hypothyroidism, the heart is like a rock. It's just dead. The brain is not working. When you push high doses of thyroxine, I have seen patients developing seizures because of pseudotumor cerebri. You can also develop cardiac failure. So in acquired hypothyroidism, when you diagnose it, start at a lower dose and step up gradually over a period of time, giving time for the body to accommodate this change. As the higher the TSH, I always start at a lower dose and gradually step up. So the maintenance dose is 100 microgram per meter squared body surface area, or it could also be based on weight. 4 to 6 microgram per kg body weight for 1 to 3 years. For 3 to 10, it is 3 to 5. For 10 to 16, it is 2 to 4, and young adults 1.6 to 1.8. Further dose adjustments will be based on thyroxine TFT tests. Mohan, if I'm overshooting my time, just tell me, I'll stop. So this this is again the chart again in the standard treatment guidelines. So you have an abnormal thyroid function test. If your TSH is more than 10, you know it is abnormal. You will work up for antibodies and look for other reasons and treat. If the TSH is 5 to 10, it is neither here nor there. You will not treat immediately. Look at the total T4 and then also look at the antibodies. This is thyroid peroxidase antibodies. If the T4 is normal and antibodies are negative, just keep watching. And the reasons for this could be obesity or drugs. So you have to repeat thyroid function test. If it is the T4 is normal and the antibodies are positive, keep monitoring them. I have some patients on follow-up for several years and they continue to be euthyroid. So till they develop definite hypothyroidism, I don't start thyroxine. Then you have a normal TSH and a low T4. So here you're a bit worried because you remember we talked about congenital hypothyroidism in the earlier part where you thought of central hypothyroidism. So if you will check free T4 now. If the T4 is low, but the TSH is normal, check free T4. If that is low, then it is central hypothyroidism you have to treat. But if the T4 is low, but the free T4 is normal, it is either due to protein deficiency or a thyroxine binding globulin deficiency. You don't need to treat these patients, you just leave them alone. And this is the reason why we kept on talking about total T4 / free T4 in the earlier part of the lecture. So we go to the next scenario. So we have a 8-year-old girl whose BMI is more than 95% for age. Her T4 is within range. Her free T4 is again within range. Her TSH is slightly elevated. For a 5, she's 5.96. Her antibodies are negative. She had been started on 12.5 micrograms of thyroxine. What is this? This is obesity-induced TSH elevation. You need to stop thyroxine and reevaluate, but because it would still be an evolving hypothyroidism. But this is due to effect of leptin on various hormones. So quite a few of these obesity patients can have TSH in the range of 8, 8.5. So unless you have definite clues for hypothyroidism, please don't start thyroxine. Excellent. We have a 13-year-old girl who's constipated, tired, sleepy. I think this is a very common scenario in the times of COVID. She has a menstrual cycle which is about 40 days and lasts for about 3 days. She gained 6 kgs in 6 months because most of them have become couch potatoes now. The T4 is low. So 5.5 to 12.8 is normal. She's 3.6. Her TSH is normal. The other systems are normal. So, but you check free T4 now. That is absolutely normal. 1.2 for a range of 0.8 to 2.2. So the diagnosis is thyroxine, thyroid hormone, binding protein abnormality. So these patients don't need treatment. TBG deficiency can happen 1 in 4,300 infants and it's much more commoner in boys. Boys is to girls is 9:1. T4 would be low. TSH would be normal. But then the free T4 also will be normal. If the free T4 is low, then it becomes central hypothyroidism. If you're unaware of this, there would be unwanted investigations and treatment of these patients for central hypothyroidism. Thank you so much for this kind of opportunity. And I owe a deep, deep round of thanks to my mentor, Professor Raghupati, and also my co-authors of the standard treatment guidelines on hypothyroidism, Dr. Ravindra Kumar and Dr. Tushar Kodpalli. Thank you so much.
Thank you, madam. Actually, I have also just a few, I put a condensed one of those slides. I'll just show that also for the last being, if there is time. Dr. Siby, can I just show the slides? Two slides I have made.
Yeah, sure, Mohan. Please.
Yeah, just to make sure that we are, I think the screen is visible now. Is the screen visible now?
Yes.
Okay, thank you. So just because to condense what madam has told, it's difficult, but I have tried to make it just to show you how it's made. So usually there are some challenges which are diagnostic, there are therapeutic, as well as madam has shown in beautiful case summary, there are many patient perspectives also. So they vary according to scenario which we have told, but usually congenital hypothyroidism is straightforward and should not be missed in clinical practice. So madam has also told about the thyroid hormone journey from the synthesis, and there is also some congenital causes, genetic causes which not to be missed. There are some MCT8 deficiency causing intellectual disability. There are some deiodinase disability as well as thyroid hormone signaling issues. But basically it's easy to pick up and requires only a good suspicion. Some thyroid nodules also occur in children, and these are some genetic causes because there are some students who are here who are also joined. So just to note that there are some hormonal genes also which are involved in papillary carcinoma thyroid. It's still also very common in Kerala as also. Madam has also illustrated about the role of antibodies, but just to show you one graph, in mother also we are seeing some called TRAB antibody which can cause the placenta, and newborn infant will also suffer from the Graves' disease if the mother is not properly given correction. And also if given overcorrection, it can lead to fetal goiter also. So remember that the history taking is very important from the pregnancy. So again, the condensation of all these things are, there are pre-laboratory, there are laboratory effects as well as the post-laboratory, the rare genetic issues. So you have to have an in-house laboratory assay, which is a proper commonly taken, and also include a lot of history into this picture, including the concomitant thyroid therapy, other medicines which the child usually takes, and also the maternal status, whether the child having a mother having hypothyroidism. So now, because we are in the COVID scenario, I had asked madam if I could put one slide on this, because COVID-19 and thyroid damage is thankfully not that common, but we are seeing some case reports also in this regard, because there are receptors, ACE2 receptor in thyroid cells selectively, and there is also something called TMP RSS2 in thyroid cells also. So this is the reason where there are direct damage and there is a subacute thyroiditis. I also had reported as part of the thyroid research practice along with other co-authors that in clinical practice is not to be missed, because their symptoms are mild and they completely recover in a few days, but still you can see it is very painful, and ultimately we have to be alert as well, because unnecessary starting therapy is also to be avoided. And a note about telethyroidology, because telemedicine is also there, but this article which we have published, a group has published regarding Endocrinologist Society of India, because telemedicine has come and is now still in full form. We should remember that to avoid hospital visits, always try to be alert, but taking a history is also important even in telemedicine, because all these things can be included in our history. So thank you once again, madam. I will just stop my screen sharing. So I think there are some questions, Dr. Ahila ma'am, should I take one by one or can I put in together?
Anything is fine. That's
yeah. So I'll just take from the below. I think there is a question from Dr. Suni. Till what age can we call it as congenital hypothyroidism?
I was actually trying to connect my external hard drive.
Yeah.
I have ectopic thyroids manifesting at puberty. So you have to remember your demand and supply. So when your child is growing, the maximum period of growth is intrauterine, next is infancy, and then puberty. So during infancy, they will manifest hypothyroidism. Some, when you have an ectopic thyroid, which is able to make enough for the child to grow well, you will not manifest. And at puberty, when their demand increases, they can manifest. So depending on what reason it is, when will you have confusion? At about 4 or 5 years of age, you will have these patients who can either be an acquired, which happened very early, between 2 to 5 years of age, or it could be a congenital hypothyroidism manifesting late because of partial dysharmonogenesis. That confusion will always happen. If you have antibodies positive, then we take it as acquired. If an antibody negative, you assume it could be a congenital organification defect. But there is no specific term which says congenital hypothyroidism is at this age.
Right. But trial of therapy is done at 3 years of age, the standard. So if you have diagnosed it early, you can always try to think about stopping it at 3 years of age, but there is no age limit for congenital hypothyroid. Correct, madam? TSH cutoff, yes, ma'am. I'll just go to questions once more. Yeah. TSH cutoff after newborn period, that madam has already told about, doctor has already mentioned. A dose of thyroxine in grown-up children after infancy, because after the initial period, the weight also goes up.
Yeah, I always use meter square body surface area. So I use 100 milligram per 100 microgram per meter square body surface area. But if your TSH becomes well suppressed with a very high free T4, then I drop it down to 80 or so. Very rarely I've had to go to about 70 micrograms per meter square. I always follow meter square body surface area because that's what I learned from Professor Rugmini, and that's what we continue to do. Yeah, so ma'am, there are 2 more questions before we end it. Dr. Bennett has asked how can we say normal TSH based on the central or TSH based on central or not, because central thyroid can have variation. How can we say that normal TSH and central hypothyroidism?
I will clarify my doubt. This is, first of all, it was a wonderful talk, and my doubt is, see, you said that TSH is normal, but it can be a central hypothyroidism. But how it can be? So which part of the brain is affected? And see, once the TSH is normal, what as a general practitioner, what I know is the brain is normal and the secretion of TSH is normal. From the brain only TSH is produced. And still, how can you say that it is a central hypothyroidism? That is my...
So the only point, I think the whole of endocrinology revolves around a negative feedback. If you have, it's inappropriately low for your low T4, free T4. If you have a low free T4, your brain and your pituitary should sense that your thyroxine supply is low and increase your TSH. If it is not able to increase your TSH to increase your thyroxine production, it means it's central hypothyroidism. There is TSH, but it has not been able to compensate for the reduction in your T4 and free T4.
Oh, you mean so that adequate secretion is not there? That is the point.
It's inappropriately low for your total T4 and free T4. The same holds good for ACTH. If your cortisol is low, your ACTH has to go high. If it does not go high, that means it's central adrenal failure.
Okay, thank you.
So we'll take one last query, ma'am, because time is short. One more question has come. You can also read that our user is not named Galaxy A50. Ma'am, for neonatal thyrotoxicosis, what is the management and what is the duration of treatment? Is it common in your area also, ma'am? Neonatal thyrotoxicosis?
I have a few. I wouldn't say it's very common and all that, but I have a few. So I think that would be a separate talk on it. That question.
Yes, ma'am. Yes, ma'am.
It's a huge talk, and it has
basically needs cardiac supports also. Cardiac and all you should monitor. Okay, ma'am. Thank you. So thank you, madam, for the excellent talk. Over to you, Rugmini, madam.
Thank you very much, Dr. Ahila, madam, and Dr. Mohan T. Thank you very much. Now let us move on to the second session for today.